Welcome to the June NASMHPD Meet Me Call. The Meet Me Call will address disaster behavioral health and crisis services. We are honored to have Vibrant Emotional Health and the state of Missouri and the state of Tennessee present on this important topic affecting all of us. From Vibrant Behavioral Health, we have Dr. April Naturali, Vice President of Disaster Services, and Amy Dominguez, Program Director of the Crisis Emotional Care Team, to discuss the critical importance of disaster behavioral health. They will cover preparedness, response, and recovery strategies following various types of disasters, including natural disasters and incidents of mass violence. This topic is essential as effective behavioral health interventions can significantly impact the well-being and resilience of affected communities. Thank you both for joining us to discuss this vital issue. Dr. Naturali, please go ahead.
Thank you, Brian, for the opportunity to speak with all of you today. Most of you know Vibrant Emotional Health as the former Mental Health Association New York City and the administrator of the 988 Suicide and Crisis Line. But we've grown and we've expanded our national work. And one of the major areas we've done so is in disaster services. Vibrant's actually been providing disaster services nationally since 9/11, when our crisis call center, LifeNet, not yet the suicide line, that hadn't started, began responding to people in distress from all across the country. We've also worked very closely with the state and SAMHSA at that time, especially, to design and deliver one of the largest public mental health campaigns in the country, which was really successful in reaching people in the New York tri-state area with messages that provided psychoeducation, support, and resilience, with statements like, "We're all in this together," "Even heroes need help sometimes," and many others that reached over about 8 million people for about a year and a half that program went on, or at least for the public health campaign went on. After that, we administered the 9/11 10th Anniversary Healing and Remembrance Program with the Office for Victims of Crime funding. And then with SAMHSA and BP funding, we launched the Oil Spill Distress Helpline. Can you show up the next slide then? This is an example of some of the public mental health campaign posters that were in subways, buses, everywhere we could put them up throughout New York City. The Project Liberty was the name of the program. And the next slide, please. And so here you can see the campaign around the oil spill, the 9/11 10th anniversary, and Scars of Hope we'll talk about in a minute. With BP funding and SAMHSA administering, we launched the Oil Spill Distress Helpline, again, providing psychoeducational information, which we know can decrease anxiety, support, resources, and referrals. So that line then morphed into what we continue to have today, which is the National Disaster Distress Helpline. And Amy will talk a little bit more about that in a bit. I think most of you are more familiar with that line than any of the past work. So that's our past history in disaster work. More recently, around 2018, we partnered with and then acquired Disaster Psychiatry Outreach, which, as many of you may have known, was a unique and special group of psychiatrists who really understood the difference between formal mental health services, which most of you in your agencies and throughout the state provide, and the acute traumatic stress responses that occur after a disaster and other types of emergencies and crises. And we know these responses are generally short-lived, with most people recovering with a reasonable amount of time, with good coping, which we try to teach and train, and with good social support, which is most important. So we follow this non-pathologizing model of care, which so many of you throughout the country in each of your states know based on having already run some crisis counseling assistance and training programs, those CCP programs that SAMHSA and FEMA fund when you have a disaster. That's the model that we follow. From our joining with DPO, the Disaster Psychiatry Outreach Group, we developed our Crisis Emotional Care Team, which my colleague Amy Dominguez is going to talk about in detail. And just last year, we created a full-on disaster services department within Vibrant that offers extensive training and consultation, as well as the direct services that our crisis emotional care team offers. And we work with states, with different agencies within the states, private organizations, and even individual communities addressing the impacts of disasters and crises. We've actually been very busy since day one, providing disaster planning for some of the states and different agencies. We offer psychological first aid training for many agencies, which I think many of you know is the best practice for disaster response, different from mental health first aid. Understanding mental health first aid as that tool which helps us identify people in the community who may have a mental illness. And again, the psychological first aid is a non-pathologizing model. We try to understand the acute responses that are not likely mental illness, and we can talk about that a little bit more as well. So there have been an overwhelming number of disasters or incidents. We've responded to cluster suicides. We've worked with many healthcare agencies dealing with a significant wave of burnout, as many of you are aware, as a result of the pandemic. And there are many, many more requests since day one. We've been very busy and we continue to be. Earlier this year, we acquired Stars of Hope, which is a narrative and art-based disaster response program. And we continue to grow. It's our goal and our hope that you will use us as a resource for disaster and crisis-related needs. We will do consultations. We will have a needs assessment done if that's what need be. And I'll let you know here that we are not funded by SAMHSA or any other government agency at this time, although we're hoping to do more with SAMHSA. You know, we do respond to RFPs from them, from the CDC, from other agencies. But right now we have private and foundational funding, and that allows us to do some pro bono work, depending on the scope of what that work is, if it fits within our grant scope. And with other work, we try to charge reasonable amounts that the agency or especially states that you can manage within the guidelines of your grants and your budgets. So I just wanted to give you that background and continue to ask you to reach out to us for any kind of support that you may need, whether it's resources, referrals, training, consultation, or direct service. So I'm going to turn it over to Amy Carroll to give you more detail about our work. Amy?
Thank you. We can go to the next slide if you don't mind, please. So the crisis emotional care team, as April mentioned, really has been around in various iterations for 2 decades. But when we brought this under Vibrant in 2018, we really wanted to build not only a team of individuals that were willing to respond when a crisis happened, but a community where people could learn, grow, and continue to be aware of best practice when it comes to disaster mental health. It isn't a surprise, I think, to many of us here that mental health is often seen as the kind of an unspoken need in many communities. There's a lot of stigma around this conversation. And when someone hears that a clinician is in the room, it can result in some negative emotions. So what we do is work with organizations already established in the community that have trust and relationships for years and come alongside them in providing support. And that can look like a myriad of different iterations. It can be direct service, as April mentioned, where we are providing mental health support, crisis support in those acute phases of disaster. It can look like providing training to organizational leaders and team members who are active on the front lines of disaster and ensuring that mental health is not just part of their own care of the community, but also of themselves, of knowing when they are reaching points of burnout and really taking a trauma-informed approach in ensuring that people are not leaving organizations and with that taking their institutional knowledge, but ensuring that leaders are equipped with building a culture of workforce protection and intentional care, because this work is hard and it is seemingly unrelenting. And it's important that we're creating that space for one another to be the best that we can be in achieving our mission. Our cadre has over 1,000 people across the country. One of our team members talks about providing care from Maui to Maine, but we've also been invited to some international conversations with the recent incidents in the Middle East, and providing some support to people as they are processing what is a really unprecedented exposure to trauma, as we are watching really graphic images of children and of families that are being brutalized overseas. So we offer just-in-time trainings that we stand up on a regular basis. It's often attended by well over 300 people each time. And we do this in a way that tailors it to the audience that we're speaking to. So a lot of times we're talking to mental health providers, but we are also talking to people who are just trying to do their best in helping out and serving their local communities. April mentioned we provide very specific trainings that are tailored to organizations and team members, such as psychological first aid, which we know is available for free online, and we do encourage people in that direction. But oftentimes when delivering psychological first aid, it is important, context is and culture are important in that delivery. So we're intentional on that front as well. And then we do a list of other trainings that include leadership development and ensuring that folks have effective grief and coping skills as they move forward in their work. You can go to the next slide. One of the other areas that we work in as a team is in developing ways of looking at disasters and their impact. And we have taken, some of you have seen this before. We've developed the model for adaptive response to complex cyclical disasters. This is just a screenshot of a portion of that model, but would encourage you to check that out. What we do is basically create a framework for people, regardless of their role in a disaster response, to help identify what to expect and what is anticipated when layering disasters are occurring. This was created as an impetus after the pandemic, recognizing that burnout and exhaustion were very real in a very acute way, and that other disasters didn't stop just because the pandemic was part of our reality. So this model, which builds off of the traditional SAMHSA model that has been used for decades, it gives an understanding of how we can address complex realities as disasters add additional stress to our lives. The next slide, please. If you are ever in need of support, if you want to have a conversation within your own organization, feel free to reach out to the Crisis Emotional Care team in these two ways. We have an email, but we also have a page on our site that allows you to submit a very specific request. So would encourage you to do so. We can go to the next slide. The final piece in our work is right after the pandemic, we as a team decided it would be really helpful for folks to get together and talk about some of the innovations happening in disaster mental health. And we started an online gathering, as many of us did in that time. And we found it to be incredibly well attended, and the presentations being really engaging. At the time, it was just a one-day event. But last year, we were able to hold our first in-person conference in Washington, D.C., and very excited to be hosting our next conference in Nashville this coming year. I want to just note that we picked Nashville and we picked the places where we have these events in a way, frankly, to honor the work that Tennessee as a state and Nashville specifically as a community have responded to what has been unprecedented numbers of incidents in the last few years. I'm going to turn it to April to speak a little bit more about what our conference holds this year, and would hope to see many of you there.
Thanks, Amy. We really urge you to send staff or join us yourself. This is a real opportunity for people to come together and learn about how we as a mental health community, as responders, as agency leaders, how do we respond to communities? We know disasters are increasing, all different kinds of emergencies are increasing. And as leaders especially, we can really help communities either move on to a recovery path or not. And the staff really do look to leaders to help with this guidance and how we get there. We are thrilled that this year we have Dr. Robin Stern and also Dr. George Bonanno, two leaders in the area of resilience. We played around with the word a lot because, in our society, we tend to kind of overuse words and then they lose much of their meaning. So our goal was really to show in this conference, what does it mean? What does it mean to be able to manage an emergency, a disaster, to continue to function, to continue to connect with others in your community, to work towards recovery rather than being stuck or going on to develop a mental health problem, and especially to begin to have joy again. As we see people suffering, we also know that we have to move on. And so we really wanted to give a definition of what does it mean to be resilient. Dr. George Bonanno has been one of the primary researchers in this area. He's very concrete information about what this looks like, especially from his studies. And many of you may know Dr. Robin Stern, who's written about this from many different lenses. They bring so much to us. We also have from NYU. Again, they're doing studies on folks who are within communities that may or may not have the same resources as other communities, whether it's because they're communities of color that have been left behind, communities that have no resources or in low socioeconomic areas. And we're continuing to see line up different keynote speakers, but it's going to be 2.5 really full days. And a full day on the first and then half day on the second. So we urge you, if you take a look at the QR code, you can see what's going on. There's a lot of states and models that some who you'll be hearing from today who will also be presenting at the conference. So you really get a chance to see how other states are managing and how agencies are actually working together and community foundations are working together with the states in responding to disasters. It's also a great opportunity to network. We know there are very few conferences that are focused specifically on this work, so it's a real opportunity. We hope you can join us. Grab the QR code and or the website link and check it out. Thank you. Can we go to the next slide? We wanted to, as we close up here, talk a little bit about the Disaster Distress Helpline. As you probably already know, this is a line that is part of the 988 network. So it's actually the same crisis centers who are in the 988 network who specialize in working on the Disaster Distress Helpline. And so similarly, the calls are routed through the same technological system, the telephony system that we use for 988, going to the closest crisis center to the person's area code from wherever it is that they call. It is multilingual. We offer services in Spanish specifically by pressing 2. There is the video phone. We're thrilled that we have deaf and hard of hearing agency, the one crisis center in the country that we work with, who will get on a video phone to work with folks who are deaf or hard of hearing and use ASL. And we also, as part of the Disaster Distress Helpline, we do have a moderated online peer support. We use Facebook as the model for this, as the base, to provide crisis support over Messenger on Facebook for survivors and responders. And again, this is 24/7 moderated. So we have trained, skilled crisis center staff who are using the online peer support and addressing those who dealt with a disaster. Mass violence events is probably the largest group that we have talking to each other in the Disaster Distress Helpline. And again, it's a 24/7 service. Anyone can call or text, and you can see the number up on the screen, as well as going to the web if you want to get to the crisis center's crisis over messenger support for survivors of disasters. Next slide, please. We have additional ways to reach our resources. You can go directly to the Disaster Distress website, which is through the SAMHSA website, and Strength After is the online peer support. They're very active in social media, and we've lots of information that we can share. So please do use us as a resource. And if there's anything that you need, email the ddh@vibrant.org, and I'm sure that we'll be able to respond to your needs around disasters and other emergencies. Amy, any last comments?
No, just thank you for the chance to present. We're honored to do so. I think we're turning it back over to Brian.
Sorry, I hope I'm unmuted now. We are now delighted to have Becky Gear, Director of the Office of Disaster Services with the Missouri Department of Mental Health. And from Tennessee, we are delighted to have Jennifer Armstrong, Director of Crisis Services and Suicide Prevention, and Andy Lawrence, Assistant Director of Crisis Services and Suicide Prevention with the Division of Mental Health Services. They will share insights on how their states have implemented disaster-specific crisis training and developed tailored programs to meet their community's needs. They will also emphasize the crucial role of relationship building and collaboration with other departments and organizations in delivering effective disaster behavioral health services. Thank you all for being here. Becky, please go ahead.
All right, thank you. Good morning or afternoon, depending on where you are currently. Our office in the Missouri Department of Mental Health, Office of Disaster Services, focuses on all things disaster, man-made or natural. Everything we do is centered around planning and preparing, mitigation, response, and recovery for and from an event. What I'm going to focus on today is the response and recovery piece and share about the Missouri Disaster Behavioral Health Program. Next slide. Missouri has a lot of disasters in our state, and because of that, we have two focus areas for disaster response. I'm going to mostly be talking about our behavioral health strike team today, about what it is, what challenges we've had, the trainings we require, the specializations of the team members, how we deploy, and what responses might look like. But I'm also going to quickly highlight at the end our Missouri FEMA crisis counseling program that we use often as we move into disaster recovery. Next slide. So the Missouri Behavioral Health Strike Team is a team of trained individuals from our communities who we request to deploy to various events as soon as their assistance is requested. We never deploy without being requested. These types of events have to rise to a certain level of a disaster for them to be able to respond, and that's usually a man-made or a natural disaster. In 2017, we really recognized that we needed to shift how our disaster responses looked. So we held a disaster summit where we brought in subject matter experts from local, state, and national levels to talk about the various disaster responses and what we could really develop and formalize for Missouri and our processes. Then in 2018, we had a disaster. And so we tested the process that we had developed by deploying myself and a group of people to this specific mass fatality event. And we were able to determine that what we had developed really worked well. It helped us expand upon how our team looks and how we grow. But one of our biggest takeaways from this is that we really needed to deploy someone from within our department, specifically within our Office of Disaster Services with the team, so that folks in the disaster services area could focus on logistics and organization and coordination needs, so that the strike team members could focus on what they needed to do with the community without losing time trying to navigate the disaster scene in the system. However, there's been challenges and lessons learned in the creation of this team. And I would say our biggest challenge happened with COVID. Like many of you all, we saw our numbers drop with the great resignation that happened around the country. We went from having hundreds of team members on the strike team to around 30 people on the team at one point. We really believe that people were scared to deploy during COVID. It was the first time we were asking our team to deploy to an event that held a risk to themselves or their family members. So much of our time over the last couple of years since that pandemic has been spent trying to really rebuild and grow and train up new staff members. Our recruitment was initially staff members at the certified community behavioral health organizations and some of our Department of Mental Health staff. But we're starting to expand now to other organizations, agencies that we partner with, those grassroots organizations or community members who've been part of the crisis counseling programs and really want to continue to work in disaster behavioral health. So since that pandemic, we have been able to grow our numbers back up into around 120, I think is where we're at now, and we're continuing to grow each month. We utilize funding from a couple different sources for our program. We utilize funding from SAMHSA, and we utilize funding from ASPR and the CDC as well. And I'm going to talk as we go throughout the presentation just about some other challenges and lessons learned, but let's go ahead and go to the next slide. So in the first year of joining our behavioral health strike team, we require the members to attend 4 courses to get some basic disaster training. We require NOVA, and NOVA is the National Organization for Victim Advocacy, and that gives a basic training to give trainee skills on how to respond to different disaster crisis events in their community. So different crisis intervention skills, providing education and emotional first aid in that aftermath of that critical incident, whether it is a small or large event, whether it's a natural or a man-made event. We also require psychological first aid, which you heard Vibrant talk about. We require that because that teaches individuals how to help those in the community in the immediate aftermath of disaster and terrorism. And we also require incident command systems, or what we call ICS, some basic understanding to help them see and know what that disaster response structure will look like. So NOVA is an in-person course, but the others are all online, and we find that virtual seems to be the way most people want to learn since the pandemic. We do, after that, ask people to take 2 trainings a year, and we offer several trainings throughout the year that they can take that will meet those needs. Annually, we host a summit that we bring subject matter experts in to train the teams. This year's summit, we partnered with our friends at Vibrant to bring in members of their team to discuss how psychological first aid is actually used in real world situations, what that implementation looked like, and how it worked. We've also found, as I mentioned, that virtual seems to be the way people are wanting to start taking trainings. And so many staff are having a hard time attending in-person trainings. So we're starting to think about, how do we do this in a non-in-person and more virtual type of setting? So this year, we also partnered with Vibrant and the National Mass Violence Center and NOVA to do virtual trainings on specific topics. And each training we ran for about 1 to 1.5 hours. We recorded all of them so that we could use them in the future for not only our current strike team members, but those that want to join in the future as we have attrition and those needs change. We did virtual courses with Vibrant and our partners at the other agencies on things like addressing grief, caring for children in disasters, community violence and school shooting events, the Mark D model that you saw Vibrant present on one of the screens. We did a NOVA refresher and a just-in-time training as well. Next slide. We also have specializations that we house within our behavioral health strike team. So you can see some of those on the screen here. We base these specializations on types of events people have deployed to and trained for. So things like if they've gone to events where there's been children present or schools, mass violence. Also things around repatriation, which is when we're bringing US citizens back to the States when something like war or terrorism happens overseas. Also listed on the screen is what we call VIC, a Victim Information Center. And this is a specialized reunification center where our strike team works to help reunify loved ones with their loved ones' remains when people are either missing or dead. Next slide. We have 2 systems we use with the behavioral health strike team to kind of track and deploy. Our first system is just a standard SharePoint system where we house training certificates for our members. We track their contact information, any specializations they house, and it allows us to really kind of filter out for specific deployments who we want and based on specialties and where they're located in our state. We also use a mass notification system called Groupcast to send out text messages and phone calls when deployment opportunities are available, or even when there are full-scale exercises that there is an opportunity for members to attend. We also use Groupcast to send out emails to keep staff up to date on available trainings and relevant information, and we do a quarterly newsletter that we push out all trainings and just general information for our strike team members through. Next slide, please. So deployment for our behavioral health strike team can happen very quickly. The expectation is that they deploy within a couple hours in some situations. In other events, they may be on standby or asked to deploy within 24 hours. And the types of events that they're asked to deploy to all look different. These events can, as I mentioned earlier, be natural or man-made events. Your deployment may last from a day to 2 weeks, and it may run from 2 hours to 12-hour shifts, depending on the situation. And our teams can work in any capacity that's needed. We've handed out water to responders. We have helped create lists of medications that people needed during a train derailment. We've helped just talk and listen to someone who's experienced the event itself. We helped link survivors to resources. We've done debriefings, and we've even walked through that death notification process. Next slide. We often get asked by people, well, where will you deploy to? And my answer is usually anywhere that is needed. They can go into a shelter. We've gone into schools. We've been housed in hospitals before. We've also gone door to door in neighborhoods. We've also been deployed to places like a morgue or alternate care sites during COVID. Next slide. Some of our past deployments that are on the screen here, we've gone to the Branson Duck Boats, which was our first test of our concept of operations for our strike team. And that happened in 2018 when we had really a freak accident, but turned into a mass fatality event in Branson, Missouri. We have, as I mentioned, deployed in COVID to St. Louis to an alternate care site and a dignified transfer facility, which is really a fancy name for morgue. We have deployed to an Amtrak train derailment and then a school shooting that has happened. But we've also deployed to many natural disasters, flooding and tornadoes, which we have happen a lot in our state. Next slide. There's also always challenges. As you know, things are always changing. So for the future, we're starting to look at how can we do this better? How can we change? How can we grow with the times? So some of the things you see on the screen here are things we're working on. We've created a work group with our partners at our behavioral health agencies to really review and update our concept of operations, address recruitment and expansion, and identify how we continue to do training and exercising when people have a hard time leaving work because they are so busy. Some of that comes into working on developing virtual training. So I mentioned the virtual training we did with Vibrant earlier. We're now looking at how do we develop a virtual training to help people understand what it looks like to deploy to a situation. If they can't come to a full-scale exercise that we do with our emergency management partners, then how can we help them understand what that looks like by creating virtual trainings, utilizing what has happened at those full-scale exercises. We're also looking at recruiting from other entities outside of those CCBHOs, and we're starting to pilot how that would look in our communities with a tiered deployment system. So what that means is we would start with our CCBHOs, and then if additional staff are needed, we would deploy from other agencies within the communities who we can train as part of the strike team or have already been trained as part of the strike team. We also have staff that part of their job is just to travel around to regional and local meetings with emergency management and with school personnel to help educate them on what the behavioral health strike team is and how they can assist. And then, as I mentioned, we've done annual summits, but we are now moving away from our annual training for our strike team and going to focus on doing a disaster behavioral health conference that those strike team members can attend, where we can also try to do more education for the community as a whole, but also recruit more members to our strike team at that. And our friends at Vibrant are going to be coming to that. It'll be in April of next year and be presenting there as well. Next slide. Lastly, I want to mention the Show Me Hope program. And if there's a federal disaster declaration for individual assistance in the state, the Missouri always applies for the FEMA Crisis Counseling Program, or what we call the CCP. After the initial deployments, if we receive the declaration, we shift from our behavioral health strike team response to our crisis counseling program, which can then take that response and move into disaster recovery in our communities. I mentioned in Missouri, we have a lot of disasters, and on the screen, you can see that the last 6 CCPs we've had in our state have been pretty recently. And currently we have a disaster request pending for a declaration due to tornadoes and storms in the southern part of our state. So potentially we have another CCP that will be standing up in the near future. Our CCBHOs in our communities are who work the CCP while we at the department oversee that program. And our CCP in Missouri is branded as Show Me Hope Missouri. So the CCP usually lasts about a year to a year and a half, which helps our individuals and communities recover. It helps them build resilience. It provides emotional support and education. And lastly, it makes referrals when individuals need that additional support and treatment for mental health or substance use disorders. Next slide. Okay, so I know that was a lot of information in a short amount of time. But please feel free to reach out to me with any questions, and I'll look in the chat as well to address those. On the screen here is our Office of Disaster Services website on the screen, and our Crisis Counseling Program website, along with our social media channels in case you would like any additional information. Thanks for allowing me to present to you today, and I'm now going to hand it off to Tennessee.
Good morning here in Tennessee. I'm sure it's afternoon in other parts of the country. Thanks so much for having Andy and I. As said earlier, my name is Jennifer Armstrong. I'm the director for the Office of Crisis Services and Suicide Prevention within our Department of Mental Health and Substance Abuse Services. And Andy is our assistant director. We could not be more excited to be here. I always find it so interesting on these calls and working with other states, how similar and yet different things look in terms of structure and implementation of services. And I really appreciated your presentation. It was great. In terms of our structure in Tennessee, our Office of Crisis Services and Suicide Prevention, we visualize this kind of 4 buckets, with our crisis services and our crisis continuum kind of being the largest via our crisis call centers, our mobile crisis teams, and all of our community stabilization services across the state that include walk-in centers and our CSUs. We also have a bucket that is our 988 system that we also oversee. All of our suicide prevention initiatives would be the 3rd, and then the 4th, which was added to our office in 2020, and that is disaster management and emergency response. I think where we're different from the previous presentation is our strike. We also have a strike team and a strike initiative, but it's housed within our Department of Health. So we work very closely, as outlined earlier, kind of within that handoff over to, when an initiative turns into a crisis counseling program. So Andy and I are going to really focus around our CCP programs, and then speak a little bit to emergency management, where, an immediate response to a critical incident might occur. And that is really in partnership with our local crisis providers. So the main focus for today is going to be on our short-term and long-term crisis counseling programs. Next slide, please. So as you can see, unfortunately, Tennessee has been hit pretty hard over the last 4 years with disasters. It's been disaster after disaster after disaster. Most often we have 2 crisis counseling programs going on at the same time. And there's never been a time since 2020 that we've not had a crisis counseling program in place, unfortunately. As you can tell from this slide, obviously, COVID was mentioned earlier. It involved all 95 counties in Tennessee. So all of our 12 crisis providers were involved in that initiative. Then moving into March of that same year. And then you can kind of see we had several in 2021. We've already had several in 2023. And so the majority of these are related to tornadoes and flooding. Actually, all of them are related to tornadoes and flooding, which we see a lot of tornadic activity as of late. So I really appreciate Andy when he joined our team. That was his main role, and we've since hired someone to be able to really focus on this portion of work within our office. And I think, when we met earlier this week to talk about this, I think that what we've learned is we've had a lot of lessons learned in terms of what not to do, and what's really been effective for us as a state in terms of identifying partners, standing up these services pretty quickly within a budget where we feel is really going to get those resources out into the community. Next slide. And I'll turn it over to Andy.
Hey, good morning, everybody, or good afternoon, wherever you're at. Listen, Jennifer, thank you for the introduction. Thank you for giving kind of that overview of how crisis counseling, how disaster management, disaster response works within our office. As Jennifer mentioned, I have been in this role for about 3.5 years. I've been in this office for about 3.5 years. And honestly, when she first hired me, I thought, disaster management, is that enough? Is that enough to fill a full-time position? I assure you, I was very wrong. We have been, it has been, like she said, kind of disaster after disaster, and we have tried to learn from each one. I think the first lesson that I learned when I look at this timeline slide, I think I had been in the office for a whole 10 days when we had our first disaster declaration, and I had never applied for a disaster grant. But I saw that I had 2 weeks to get the application in, which sounds like a long time. Once again, I was wrong. 2 weeks is not a long time. It is a tremendous amount of work. It's kind of hurry up, contact a whole lot of providers, a whole lot of other state agencies, and really work to get that application for the ISP into SAMHSA by the deadline. What you'll hear as I go over the next few slides, the biggest lesson I think that I've taken away from this, from working in disaster management within our state, is the need for relationship. It is, relationship again with those community-based providers. It is relationships with our own emergency management agency, Department of Health, our fiscal, our contracting department. Those relationships are essential to standing up any program to ensure that we're getting the help out to the community members. So, we go through, we apply for the ISP, that immediate services program. And really, in the interim, while we are applying, while we're waiting on the decision from SAMHSA and FEMA on that, the Department of Health strike team has already kind of gotten on the ground in those communities to ensure that not only are the community members that are impacted being supported, but also the first responders. We try to place a really big emphasis on taking care of the caregivers. This work, crisis counseling, the nature of it is heavy, and we want to make sure that those responders have the resources that they need. Once the ISP is awarded and that work begins, then we start the application process for the RSP, which is that regular services program. RSP, typically lasts about 9 months from the time it is awarded. It is very common in our state to get an extension or multiple extensions of that ISP while the RSP is still being reviewed by SAMHSA and FEMA. And when I was mentioning relationships, having good relationships with the federal partners as well, both at SAMHSA and FEMA, have been essential to our program's success, I believe. That kind of gives the timeline of what these programs look like, applying for these programs, what that looks like. Next slide, please. One lesson that we have learned as we've implemented multiple CCP grants or CCP programs is the importance of doing a thorough need assessment. Tennessee has 95 counties, and they are all extraordinarily different. If you look at Davidson County, where Nashville is located, it's very, very different. The needs of the community are very different, oftentimes, from our more rural counties. So we have started working, our disaster management program manager works very closely with the staff at TEMA, which is our Tennessee Emergency Management Agency, to review the individual needs of the counties that are impacted. We had one of our grants recently impacted Rutherford County, Tennessee. Rutherford County is a very large county. It contains Murfreesboro, which is a kind of a booming area. But Murfreesboro was not impacted so much by that disaster, but a more rural area of the county was. So making sure that the resources that we are requesting really meet the need of the county instead of trying that more blanket approach, which just seemingly doesn't work quite as well. So the needs assessment has been just a tremendous improvement to our overall process. Next slide, please. So some of the outreach that our providers have been able to accomplish in Tennessee, again, that crisis counseling, and that's both individual as well as group. What do we find when we talk with our providers? Very often, people in the communities, they want to be heard. They want to be heard on what that specific disaster, how it impacted them, the feelings that they're experiencing. Having that trained staff available to help maybe even a little bit normalize what they're experiencing has been just a tremendous asset in so many communities across our state. So we do have a good number of those individual and group interventions. Primarily, the group interventions are happening either in schools or in senior or community centers. We are able to really impact a lot of lives to really provide that support that those individuals need. Our providers have also done a tremendous job of attending community events, and these can be in the forms of county fairs. These can be in the form of community parades. They really just get out and get the word out there that help is available, and as well as providing even just some brief education on, hey, these are some of the symptoms that a lot of people experience when they've been subjected to a disaster. Those have proven extraordinarily successful. A lot of billboards going up in communities, and really kind of targeting those high traffic volume areas to really maximize the impact of the information provided. And then the kind of the last part of the outreach is the resource linkage. For those individuals that do need some more, they do need maybe more therapy, they do need connection with more mental health services, really having that knowledge base in those communities of what services are available and providing that smooth handoff from the CCP program to the community provider. Next slide, please. Some of the successes that we have experienced in providing these grants, again, just that collaboration with staff at TEMA has led to increased efficiency in both our application process as well as our implementation, kind of standing these programs up. We could not do that without our friends at TEMA, and being able to pick up the phone, being able to send an email and get a quick response has been just a very, very valuable tool for our office. Again, that needs assessment in the application process has led to more accurate budgeting forecasts. We want to make sure that we are requesting enough funding, but not a huge overage of funding. We want to make sure that it does meet the needs from that specific disaster. Our state disaster program manager in our office, she has really been able to work with provider staff to ensure that data capture in the ODESI system, which is what is used for the CCP grants. Providers are pros at this now. They understand the importance of providing timely data. They really do work well with our program manager to make sure that we are able to kind of track, are we getting close to our stated goals in our application? Do we have some needs for additional support? And then I think one of the most exciting parts that when I was directly overseeing the disaster grants was really having kind of these weekly provider calls. The providers are really able to share. They're really able to increase efficiencies. What outreach methods may have been impactful, which ones kind of fell flat. But really, they share things all the way from billboard design to promotional material design, as well as, hey, in this community, I found this resource. Again, just really helpful collaboration there. Next slide. Jennifer, I'll turn it back to you.
I think for the sake of time, we're going to maybe skip this slide. I know we're right at 11:50. I don't want to go over too much. We'll go to the next slide, please. And I'll turn it back over to Andy.
All right. Again, just quickly, kind of a few lessons learned. When I was working on this slide, I really almost on number one stopped at foster relationships, those relationships just across the board, but certainly with our local community mental health providers, having those relationships, again, being able to pick up the phone, same with TEMA, same with our federal partners. It really does it is essential to standing up a successful program. And then, having frequent and ongoing communication before a declaration and through the entire process, and determining a right-sized budget. Really just working with providers to understand what the needs of the community might be, what the needs of the agency are, and making sure that we are creating a budget that is right-sized for what those needs are. Next slide, please.
And I think we'll skip this slide too. I know we're over time, and I want to make sure we have plenty of time for questions. I know that Andy, you had covered a lot of the successes already, so I don't want to belabor that. But again, I think the one thing more than anything is the focus on what the community actually needs. Because a community, Davidson County here in Nashville is very different from the needs of, for example, Tipton County, my hometown in West Tennessee. So we have to be cognizant of that. So thank you so much. Here's our contact information for any questions at all. Feel free to reach out to us via email or phone. We're happy to help. Thank you so much.
All right. Thank you, everybody.
Thank you all so very much. This is invaluable. I think every state is experiencing some kind of a disaster or will. And I think for some reason it feels even more commonplace, which we talked about in our planning call, how commonplace it is, and that many of the disasters are not necessarily making the news, but they definitely affect the communities and just how impactful those local disasters are. Can each of the states, as well as Vibrant, talk more about the role of social media in disasters and how that can positively and negatively affect things? Go ahead and jump in, or perhaps we'll start. Yeah, go ahead, Becky.
All right, sorry, I couldn't get off mute.
Yeah.
Yes, we use social media. We have an Office of Disaster Services page that we use, that we push out a lot of the planning and preparedness, but also recovery information after a disaster happens. But we also, with our CCP, our crisis counseling program, have a standalone Facebook that we turn on and turn off. Seems like we turn it on most times, just with the number of disasters that we have, where we share a lot of the resources and information so that people can get it's almost redundant. It's a lot of information happening in a lot of different ways, but we want to make sure it reaches everyone and everyone utilizes different channels. Not everyone utilizes Facebook, so we may use X or Instagram or LinkedIn, right? So we have to go a lot of different channels, but we've also utilized Google and YouTube and marketing and media that way to reach folks who maybe are on Snapchat or TikTok.
And then if I could answer that question from a different perspective, that we face often when talking with organizations and with individuals is that, in the day and age that we're in, we are exposed to everything. And I just want to say that it takes it is important, I'll say it this way, to think about in implementing a practice of discerning exposure and allowing yourself to step away from those modes of communication. And I say that as as an individual human being, but also as people responding and engaging in disaster for your own well-being. Because at the end of the day, if it doesn't turn off at all, you risk some burnout and things of that nature. So just to give a different perspective of the answer.
Tennessee will say ditto to all of that, but also to say, similar to Becky, we are really strategic in use of social media. Not only us as a department, but all of our provider agencies across the state use those as well. Not only to get information out there about the service that is available, but really frame it in a way to reduce stigma for reaching out for help. We know in some of our response we get, going to rural communities, going business, door to door to businesses. Some didn't really want to touch it because of, if I house this, I think stigma, we all know stigma is real. So we try to message it in a way that reduces stigma in reaching out, so that whenever they are approached with services, that they have they're more apt to accept those, and not only that, but hang up the flyer in the window, right? So, but very similar to Becky.
I want to add too, and I appreciated Becky talking about incident command, that when we are using social media, we really recommend that people follow the public communications and public information officer guidelines and regulations around that, because we do find that people can put up misinformation and then don't go back and fix it. So they've got some inaccurate information hanging out there on social media that somebody could just wander into and suddenly not realize it's inaccurate. So we really do recommend that people take that public information training and understand what it means to be communicating with large members of the public, especially in the aftermath of a disaster, because that kind of misinformation. So we follow the timely, accurate, and continuously checking and monitoring rules, which really can be helpful.
No, thank you. Thank you. For, every state has, as we said, has had disasters, and we just so appreciate all of you being on, because leadership changes frequently. And so we never want to make the assumption that everybody knows what to do first or second. And so if a state is kind of in between disasters, if you will, what would you recommend that they do to prepare?
Well,
I'll say this, and go ahead.
So, no, go ahead, Jen.
I wanted to make a quick note, and then I want to pin it over to Andy, because obviously he was over this, and we've never had a break. But I would say the biggest thing for us, good and bad, is that we know who to go to, right? So we basically, we continue to assess the willingness of our providers. Right now, I mean, we've got one provider that's, their county has been involved in every disaster. So they're going back to back to back, overlaps. But I would say always have a plan in place on who you want to partner with. I would think first and foremost. Andy, anything from your perspective?
Yeah, when that question came out, my first thought was maintain those relationships. And I know you've heard me say relationships a lot today, but that really, at least in Tennessee, has been just the key point on being able to move quickly. Knowing that I can pick up the phone and call TEMA, and sometimes I will even just drop an email to contact at TEMA and say, hey, how's it going? I haven't heard from you for a while. And honestly, we both kind of laugh a little bit, because we go through times where we talk just all the time, and then but it's maintaining. It is maintaining. That is a good way to keep up. Excuse me. If there's been a change in staff, anything like that.
Yeah, and I would echo the same thing. I think we haven't had a break in Missouri either. It seems we have natural disasters, and then if there is a break, we have a man-made event that happens. And so we are just back to back, and it's layer upon layer of disasters that are happening. And so when something happens in one community, we still try to encourage the other communities in our state to do the preparation, to think about planning, to do tabletop exercises, to think about how does this look for us if not only it happens at our agency, but if we are required to go in and respond within our communities, what does that mean for our agency? What does that look like? And how do we continue to just move forward when we continue to have disaster after disaster? And then on top of that, how do we take care of our staff who are responding to this?
So you heard from two of what we see as some of the most successful and really well-organized states in the nation. And I just don't want the audience to take this for granted, because the amount of work and what they do in order to be able to do what they do so well is extraordinary. I will point out exactly what everyone said, and Andy saying the relationships. If we look at a major failed response, which there is a 500-page report about out on the DOJ website from the Uvalde Robb Elementary School response, the major failure was the agencies not talking to each other, not training together, not knowing who was going to take charge, not developing a joint communication center or incident command center. These things are basics, and I know they sound simple, but until you start to do them and really implement that, I think you get the understanding of how complex it is, but also how important it is. It's not okay that you just know the agency down the block. It's work together, exercise together, have memorandums of understanding, and know what it looks like to have to respond together.
April, thank you so much. All of you, thank you. Thank you for your absolutely amazing work. It is moving. Obviously, things are back to back. I love, Becky, your point about taking care of yourselves as well as your staff. And so we will continue to have this conversation. And just thank you very, very much for being on.